So in terms of myeloma and COVID, I think probably the biggest change in practice at the moment has been for the younger patients who are potentially eligible for autologous stem cell transplantation. There's been fairly firm guidance from several bodies, the UK Myeloma Forum, from the BMT, from NICE, around not proceeding directly with autologous transplants for most patients with myeloma. And I guess that's been for two reasons. One has been for the concerns around availability of intensive care unit beds, and whilst it's not that common that we need to call upon our colleagues from the intensive care unit for autologous transplants, it does happen from time to time, and certainly we do not want to take unnecessary risks whereby we might not be able to offer intensive care to a patient who needed it. In actual fact, it's as I think has been the case across the country, because of all the additional capacity that's been put in place from an intensive care perspective, there has actually been available capacity should it be needed for intensive care. But I think really the bigger issue is the profound immunosuppression that's associated with the post-transplant period. And again, it's less of a risk about being in hospital because patients are being swabbed and obviously barrier nursed. It's more an issue of when patients go home. And so even with strict shielding and social isolation, patients are still picking up COVID at home. It is managing to get into people's houses, and they are developing it. And so even in the, indeed in the non-transplant population, something like of all the hematology patients who've had COVID, 40% of them have actually had myeloma or a plasma cell disorder, which is disproportionate to the number of patients in total. So I think it really highlights the profound immunosuppression associated with myeloma itself because of the loss of the antibody-mediated immunity, the T-cell dysfunction associated with active myeloma, and of course all the treatments that we're using, particularly high-dose steroids, also monoclonal antibodies and proteasome inhibitors, all of which used either individually or in combination are increasing the immunosuppression and therefore the risk of developing COVID in the first place. So we're really very, very aware of the risks. So we've, as I say, temporarily suspended the vast majority of autologous stem cell transplants, but that is probably going to change in the coming weeks. And I think as the prevalence of COVID goes down in the community, we are going to reach a point at which we are going to need to start transplanting those patients again. Some of those patients have simply been observed. Other patients we have been able to continue with prolonged induction, in other words, give them additional cycles of VTD, or we now have the option of using second-line lenalidomide as well. And so we've been potentially using that as a holding strategy for those patients who we're not able to proceed directly with transplant. So we've been able to use some of the new NICE approvals to be able to do that. We haven't had a large number of completely newly diagnosed younger myeloma patients, but we do have the option now of using lenalidomide in the newly diagnosed transplant eligible setting as well. The main advantage there being there not being a need to attend hospital on such a frequent basis for treatment. In Southampton, however, we already have access to home care for Velcade-based chemotherapy, so we perhaps haven't had to adjust quite as much, so we are still predominantly using VTD as a first line in the transplant eligible population. But in the non-transplant eligible population, we were already starting to use more lenalidomide, but we've almost entirely moved across to using lenalidomide-based treatment as a first line. We now also have the option of using pomalidomide as a second-line option in people who've had first-line lenalidomide. Now, again, we've had a relatively small number of patients to whom that's been relevant so far, but that's certainly something that we will potentially look to do to try and avoid the need for using intravenous or subcutaneous treatments as well. I think in terms of changing therapy, we certainly had moved very much to a much more proactive way of intervening earlier. So, for example, not only at diagnosis using the slim crab criteria, but actually at disease progression, particularly an increasing use of imaging to determine when someone may have clinically asymptomatic progression, but to have developed new imaging disease, either based on PET-CT or whole body MRI. And certainly the idea of doing that is, of course, to reduce longer term morbidity related to particularly active bone disease. What we have switched to in the last couple of months is to still doing the imaging, but having a higher threshold for actually intervening in someone who may be otherwise asymptomatic. I think it's going to be really interesting when we look back a year or two down the line, and I think it's really important that we capture that data to actually see what the impact is of not treating. So whilst it is clearly not a randomized situation we're in, we will effectively have a historical control where we would have intervened. So we've reviewed those patients, we made a conscious decision not to intervene, even though there may be some subtle changes on an MRI or a PET CT scan. Clearly that can't go on indefinitely. And so again, as hopefully the peak of COVID is now passing, we are starting to look at whether some of those patients that maybe 2 months ago, just when COVID was starting to become a real issue, we decided not to intervene on, potentially over the next month or two, we might need to change our decision and actually start to intervene, because absolutely what we don't want to do is move back to an era where we were 5 or 10 years ago, where we only treated when someone had really significant end organ damage, because obviously that's too late potentially to prevent long-term morbidity developing. So I think it's rapidly moving almost on a weekly basis in terms of what our judgments are. It remains increasingly important though that we've got full multidisciplinary input, and I think actually many of the decisions we're making now are much more difficult than they were 2 or 3 months ago, when we had fairly clearly established protocols, not just over what drugs we were using, but when to use them. And now we've got to use our best judgment based on a relatively small amount of evidence to make those treatment decisions. I mean, we're keeping lists of the delays at the moment. So just for our MDT, we keep capturing, was the decision influenced by COVID, or was the decision just a normal decision, as it were? And so obviously we haven't got any outcomes associated with that at the moment, but at least we'll be able to look back, in a year's time and look at that population where we made a conscious decision not to do something, and it's usually not to, as opposed to do something. And then we've got to try and find a way of comparing that with the previous data set a year earlier and seeing. So I think that, and the main issue, so one of my big things is about data. So, with the myeloma, UK myeloma data registry that we're trying to put together, because actually, it's just such a shame that we don't have a data registry already, because we could be effectively preemptively capturing some of that data now, but we don't. So we've got to do it retrospectively.